All right, let's move right along. We're going to go to another trauma scenario you may get as a medical director interview. At the conclusion of your course, you'll all sit with me individually, and I'll give you one medical scenario, one trauma scenario. And the trauma scenarios can be anything from motor vehicle accidents to crush injuries to burns like you just saw here, as well as penetrating injuries, pick your poison, knife, gunshot, whatever. And then wait on is 6 critical actions. So there'll be 6 actions that no kid can drop. They gotta state all 6 or you won't pass. There are 6 primary actions. You need 5 out of 6 of those. And then there's 6 secondary actions. You can have 4 out of 6. If you get all the critical actions and you miss 1 or 2 of the primary and 1 or 2 of the secondary, actually because you hit all 6 critical. So it's going to be important that you remember, especially in trauma protocol, the following. Number 1 is going to be scene secure, PPE, within whatever you can. I mean, if you got a bad car wreck and there's traffic zooming all around, traffic's not safe, I get that. Wait for police, get that. Once police got a scene secure, it's not the healthiest of environments, but it's just about as safe as you can get it. And then it's going to be your evaluation of the trauma patient. It's going to be a head-to-toe examination, recognizing the ABCs and who needs the recognition of attention pneumothorax, needle decompression, intubation because the GCS is less than 8, rigid abdomens, IV fluids to start, pelvic binders, perhaps traction splints. That's a primary action. It's not a critical action. EKGs, Brett sounds, verification of ET2 placements and such. Thank you. And so if you're writing all this down, I'm going too fast for you. Please slow me down. I'd be happy to kind of give it to you piecemeal. But when you get into your primary and secondary actions, after you do your decompression and reevaluation of the patient becomes a primary action. Evaluation of IV fluids becomes a primary action. Stabilization of long bone fractures and such all become primary. Halo effects, stuff coming from the ears, primary actions. So just keep your priorities straight, remember your protocols, and you'll get through the trauma piece. Any questions about that? All right, so when you talk about medical scenarios, when I give the example scenarios, obviously when we talk, we chat, the limitations of this type of format is that you and I are not looking at the same patient. So I give great leeway to what you may be seeing, and I tell you to ask as many questions as you can. So for instance, you've got what did I have the other night? I had a 50-year-old who came in the emergency room with a 230 over 125 blood pressure. He was noted to be lying on the floor of his jail cell at the time. It is unknown what happened to him, except that he had a small laceration on the back of his head. The patient was in his jail cell reading at the time. He was not doing anything. He is by himself, and the cell door is locked. Guards make the rounds. About 2 hours later, they see that he's down. They call EMS. EMS gets on the scene, brings him into me. When I evaluate the patient, I go ABC. Talk to the patient. He's not talking back to me. Open up his mouth. Has he got teeth? Has he got airway problems? Has he got any blood in his mouth? Is the tongue so swollen I can't do anything? Palpate the chest. Listen to the chest. Palpate the abdomen. And then down to the pelvis and extremities. And within about 15 to 20 seconds, I've got a pretty good idea of answering one of 3 questions. I need blood pressure support, in this particular case, blood pressure reduction. I need airway support, because according to guidelines, he had a respiratory rate of 6, a blown right pupil, and his eyes were deviated to the left. And then third, of course, is injury, anything and everything. The laceration, it could have been a primary trauma, or it could have been the result of him having a stroke and falling down, then hitting his head. So you don't know how that's going to play out. So in your medical scenario, you'll ask me the following questions. What am I seeing? Pupils, looking in the ears, nose, and throat. What do I see there? I'm looking at the neck. Do I see tracheal deviation? Is there any crepitus or subcutaneous emphysema? Is there chest? Listening to breath sounds, all fields. Listening to heart sounds, all fields. Abdomen, same thing. Palpation. And bowel sounds, plus minus. As long as you don't have a rigid abdomen, you can listen to it if you want. Pelvis is stable, extremities out, cyanosis, clubbing edema, any deformities. So as Matthew has accurately pointed out, it's going to be a thorough head-to-toe assessment now. And this is where you're going to take on your critical actions for me. It's not going to be airway management the first ride down. It's not going to be the tension pneumothoraxes as such. This is a medical case. So from a CVA standpoint, you're going to be looking at blood pressure reductions. That's an IV start, that's oxygen administration, that's protecting the airway. Even in these cases where they've got forced deviation of their eyes, they're not moving anything, but of course they're not responding, so you don't know that. And that they don't have anything going on acutely with their chest or abdomen, pelvis from a trauma standpoint. Because again, they came into us with just a laceration on his head and it looked like he stroked out. So your critical actions are also going to include an EKG to make sure that that wasn't a cause or a significant contributor to it. In this particular case, the patient had atrial fibrillation. And I'll get back to atrial fib in a second. The question I'll ask in a minute here is, how does atrial fibrillation cause or contribute to a stroke? Give me the pathophysiology. So we get an IV started on the patients. That's going to be another critical action. And you're going to be taking vital signs Q5 minutes. Why? Because the patient's unstable, and unstable patients get vital signs every 5 minutes. They're going to do a glucose. Big miss. One of the critical actions is check a finger stick glucose. What if he dropped his sugar to 30 or 20? He would have fallen down, hitting his head. Hypoglycemia can mimic strokes. So now that you got your critical actions, then you move your primary and secondary assessments like Matthew had pointed out. In this particular case, blood pressure reduction is going to be huge. The patient's not talking. His eyes are deviated left. He's got a very high blood pressure. And since he's not answering any questions, this is euphemistically, pragmatically, whatever it is like treating a pediatrics patient, or worse yet, a veterinarian scenario where you've got a patient and no information except what you can see and what you can feel. So you get into the see and feel mode with these patients and you decide, look, this is just too big of a stroke. Forced gaze deviation to the left or right, not responding, responds to painful stimuli on the left side by withdrawing, on the right side, nothing. And so you set yourself up for not only a Glasgow Coma scale, which is part of your primary actions, so you're going to need to know your GCS for both the trauma as well as medical. But then you're going to have to give me the choice of medication that you're going to use to reduce this patient's blood pressure. Now, that could go by local protocols, and I can tell you local protocols, although they're getting standardized better and better, still vary. So you're going to have to ask yourself, what does the National Registry want, because it's their test that you're taking. In this particular case, without any other history known, I would suggest a beta blocker. You're not going to be able to give anything PO, but low pressor, 5 milligrams IV every 5 minutes times 3 is the National Registry answer. Or, depending on how the National Registry feels that day, labetalol, 20 milligrams IV push. You got to get me that pressure down below 185. After that, we've restored cerebral vascular perfusion, cerebral vascular pressure, and at the same time, you've gotten them to at least stop bleeding or significantly reduce the bleeding from the stroke. Now, patients in atrial fibrillation, I send them to CT and I get them back, and what do I not see? I don't see any bleeds. Back to the atrial fibrillation. Jamie, I'm going to ask you this question specifically. What role did the atrial fibrillation play in this particular stroke patient?
Jamie?
Outstanding. Which atrium, left or right? All right. Let's think about that for a second. If you're in the right atrium, you go to the right ventricle, you're going to go to the pulmonary artery, you're going to go to the lungs. There's a 100% chance that the clot is going to get stuck in the lung. And so you're on the right track. Clot formation in an atrium, which is not beating or getting that atrial kick, is going to be a setup for clots. So your clot can only go in two places. If it's right atrium, it's going to go to the lung, causing a pulmonary embolism. Or if it's on the left atrium, it's going to get into the left ventricle and then the aorta, and it's going to push itself up through the carotid arteries into the brain, or the vertebral arteries into the posterior part of the brain, which is particularly treacherous. So I know the pressure of the video plus the fact that I'm talking can shake you a little bit, but think through the anatomy, and you'll see that the right atrium will feed into the lung, left atrium feeds into the brain or the rest of the body. Now, where can that blood clot go if it's from the left? It can go into the brain and stroke the patient out. It can go down into the superior mesenteric artery or into one of the renal arteries, which causes a kidney infarction. If it gets into the superior mesenteric artery, it cuts off 80% of the blood supply to the bowel. So you've lost your entire small bowel and about 2/3 of your large bowel, which is the SMA, the superior mesenteric artery. It can slip through past all of those arteries and get into the leg, and now you get called on the scene for a 60-year-old male who's got a cold leg. And you're like, well, Jesus, wrap it in a helium blanket. But you get on the scene and you feel, and all of a sudden there's no pulses. So that clot could have flipped all the way down into the leg as well. And now the patient's leg is in jeopardy. If I don't break that clot within 5 to 6 hours, I lose the leg. In a diabetic patient, probably 2 to 3 hours. So again, thinking backwards now. If I've got a clot in the vein in the leg, and it comes up through the inferior vena cava and goes into the right atrium, where does it end up? Outstanding. Outstanding. Jamie, Jonathan, outstanding. Knowing the anatomy, you know where the clot's coming from. Now, Jamie, back to you. And I'm sorry to be picking on you, but man, you're on a roll. Here we go. What's the sign and symptoms of a clot in the lung? Blue from the chest up. That would be more of a traumatic asphyxia where a person takes a trauma to the chest and they will actually have some sort of clot form within the superior vena cava or some sort of stenosis and such. You're thinking along the right path, Matthew, and I think that's a good thought. They are blue, not necessarily from the chest up, though, like you would see in a trauma directly to the chest, but they are blue. So you're going to get some cyanosis, which means reduced pulse oximetry. And then Jamie nailed the rest of it. So you're going to get a tachypnea, tachycardia, decreased pulse oximetry, pleuritic chest pain. You may get hemoptysis, where the patient's actually coughing up blood, but that's the least reliable of all the 7 symptoms of pulmonary embolism. So we got tachypnea, tachycardia, anxiety, of course. Nobody likes being a witness to their own suffocation. They think they're breathing okay, but the oxygen isn't getting to the lung because there's no blood there to receive the oxygen. Tachypnea, tachycardia, diaphoresis, hypotension in severe cases. Tachypnea, tachycardia, and hypoxemia are going to be your 3 big ones. Those 3 together account for about 95% to 99% of all pulmonary embolisms. When you throw in pleuritic chest pain, I got this real sudden onset of chest pain, and now my respiratory rate's 30, tachycardia is 130, 140, and the blood pressure is normal or not normal. You've got yourself pulmonary embolism. So let's review. Let's go back. Respiratory distress, movement of failure. And these people I tend to ketamine or paralyze right away and put them on an ET tube, put them on a ventilator, and I increase the pressure on a ventilator from a PEEP of 5 to a PEEP of 7 or 8. I don't mess around with a CPAP because I need this patient relaxed, and so that I can get more volume into the lungs that are working, and I can move a little bit more oxygen at maybe 100% of the mean air concentration, what they call a MAC. But if you can get 100% oxygen with 8 a PEEP, you're driving the oxygen into the patient, and that opens up certain areas of the lung that don't necessarily participate all the time with oxygenation. If you didn't know that, the top 15% of each lung kind of hangs out and doesn't do much. So you're getting those guys to open up. If the blood clot's big enough, your patient's going to get hypotension. So I need these patients paralyzed on a ventilator. I need a nice compliant chest wall, which means I don't want them trying to fight it. I need their muscles relaxed so that I can ventilate them with the higher volumes and the higher pressures. So let's go back to the very beginning and how we started with all this. We have a 50-year-old male who's laying on the ground in his jail cell. Nobody knows what happened, but he's got a laceration to his head. EMS arrives on the scene. You start to question him. He can't talk, but he's mumbling something. You pinch the left side, you pinch the right side, both in the face, the arms, and the legs. You don't give him a sternal rub. You're trying to figure out unilaterality here. You check his blood sugar. You check the EKG. You're checking his blood pressure to find out, is he that hypertensive? Could he have had an intracranial bleed, a subarachnoid hemorrhage, whatever it is? But you notice about the pupils, and this is one of the critical actions of a stroke patient, is the gaze to one side or the other. I sat on the right side of this guy and called out his name. His eyes would come to the midline, but they couldn't cross the midline. When you ignore one side of your world, you got yourself a hemispheric stroke, probably the worst of the worst. And these people require airway management. Don't bring this patient into my emergency department without airway management. I mean, you can. Just be prepared for an ass chewing at that point. The bottom line is that these patients cannot protect their airway. If somebody comes in and says, well, I stuck a tongue blade in their mouth and they seemed to gag, well, I can assure you they didn't. So do the right thing for the patient. So it's going to be airway management all the way across the board, and then blood pressure support all the way across the board, which is why I like ketamine to induce these patients, because it relaxes them, dissociates them. I don't have to worry about skyrocketing the blood pressure when I'm giving sedation, paralytics, while I'm sticking them with these and such. I can get them down real quick, get them intubated real quick. The beauty of ketamine, especially for the 2 o'clock in the morning cases, what if you miss the ET tube? They're still breathing, and I'm still good with that. So this all started with a 50-year-old stroke. We talked about blood clots that come from the right atrium into the lungs, pulmonary embolism. We talked about those signs and symptoms. We talked about the left atrium having the clot and flipping it up into the brain, although it could also flip into the abdomen and it could flip into the legs as well. The key, the underlying heart arrhythmia here, the one that's responsible for all of this mess, is atrial fibrillation, which is why it's incredibly important to at least get a rhythm strip and optimally get a 12-lead EKG on these patients. Any questions? Does everybody still hear me? Okay. All right. So let's lay down some new ground rules. If I ask if there's any questions and there are no questions, then each one of you just type a 2. If you have a question, of course, type the question. If you don't, at least that acknowledges that we're online, because I'm talking and I'm just reading your typing. And I just need to know that I haven't dropped off the grid and been talking to the air for the last 10 minutes. Everybody give me a 2. We lose Matthew? Okay, very good. Okay, Jamie, Jonathan, let's talk a little bit about the initial treatment of supraventricular tachycardia. There's nothing more anxiety-provoking than having this rapid heart rate and wondering, where the heck do I start? And so we look at the various types of atrial tachycardias that are present, and we really only come up with about 5 or 6. What I'm going to do is I'm going to just kind of go over them real quick. Of course, the sinus tachycardia is the big one, the person that can demonstrate the P waves. Sinus tachycardias are defined as tachycardia over 100, but less than 150. Once you start getting over 150 in an adult, 180 in a child, you start wondering, is the P wave really the only one responsible for this, or is the SA node the only one responsible for this, or is there another node that may be at play? And so you look at the morphology, you look at the, excuse me just for a second, have a baby in the room here someplace. Yeah, take him back out. No, I'm not done. You're going to be looking at the rates, but you're also going to be looking for 2 very important characteristics of this tachycardia. Number 1, is it regular? And number 2, is the QRS narrow or wide? Now, let's go over some basics. The narrow is anything less than 0.20, and the wide is anything over 0.20. In other words, a couple of boxes. Each box is 0.04. So if you get wider than 4 or 5 boxes, you got yourself a wide complex tachycardia. And the medications are involved breaking a narrow complex versus a wide complex vary greatly. All right, so if you've got a patient that's got, let's say you had 4 choices sitting in front of you. Atrial fib, AV nodal reentry, sinus tachycardia, ventricular tachycardia. Which one of these would be the irregular rhythm? Hey, there's Matthew. Hey, cool. You're back. AFib, outstanding, Jamie. AFib. So what I'm going to do is I'm going to get the emails for each of you three, because I see we're coming up on 9 o'clock here, and I got carried away with the scenarios. But I guess, no, I'm not going to say that I got carried away with it. Let's just say that I've been concerned over the past 4 years now that I've been doing this. Each class comes up with pretty much the same or similar concerns when it comes to putting it all together, so to speak, and that's the medical director scenario. So I hit that one pretty hard today, because I use cases for different scenarios that I've encountered in the emergency department, something I've had that's been very fresh. So what I've given you today is, how do you put everything all together, from paralytics all the way down to intubations, from your critical actions all the way down to EK termination. Now, the subject of our next conversation next week is going to be the paper that I'm going to send to Jane. She's going to distribute to all of you. But what it is about is evaluating the person that's got supraventricular tachycardia. And your algorithm is, if you've got shared screen on right now, the algorithm really comes down to, is it narrow complex or wide complex? And then at that point, whether it's regular or irregular rate. Those are your decision trees. That's going to bring in 5 medications if you're regularly irregular. It could bring on a synchronized cardioversion, or it could be bringing on the pronestal, the procainamide, the adenosine, which is adenocard, cardizem in certain instances, if you're carrying the calcium channel blockers, beta blockers. So those are the 4 major classes of medication. And what I want to do is want to make sure that you guys are really tight on how to distinguish between a narrow and a wide complex tachycardia and regular versus irregular wide or narrow complex tachycardia, and what the appropriate medication is for each. In each of those 4 cases that I gave you, regular versus wide versus narrow, and any combination of the 2, anything that you see there is going to have a different medication. So 4 scenarios, 4 meds. It's all possible. And then you'll find out that in a couple of those, that the calcium channel blocker can be deadly. So if you don't make the call, it's also hit cardiology pretty hard from a standpoint of supraventricular arrhythmias and what medications are given as well. It's become a sore subject within the National Registry, because there doesn't feel like there's enough emphasis on cardiology. My experience in colleges and teaching cardiology is that it's easy to get in way over your head. So I keep it basic to the 6 basic arrhythmias when it comes to treatments. They're going to require medications. So this should be a piece of cake next week when we go over this. So I'm hoping to see each one of you next week, talk to each one of you next week, and we go over this very important topic. Anybody have questions? Yeah, no, I want to do as many of these as we can get. If we get Jonathan, Matthew, and Jamie back in for another session next Friday, that would be great. If they want to bring any of their colleagues in that are in the cardiology sections, having difficulty with cardiology, have yet to hit cardiology, or have gone past cardiology and want to review, I think those would be the people that are eligible to take this class. Now, next week, when you sit down to talk with me, though, we're hit it for a solid hour. I'm going to respect that 1 hour mark. Under no other circumstance are we going to go over 1 hour. And I want to make sure that we get it synced, which means I'm going to prepare you first with sending you the paper so that we're going over it at the exact same time. Is everybody pretty clear next week? Same time. 8 p.m. Central, that's correct. And then what I'll do, Matthew, since you have impeccable integrity by announcing that you barely passed your EKG test today to put together questions, I'm going to pull your exam that you had, and we will go over some of the things. Not so much as saying this is what you missed, but I'll make sure that I hit all the highlights so that everybody is aware of where the pitfalls are. And Jamie, you're on shift next week, but you're going to try. I expect that Jane and I will come up with some way, some mysterious way to record these things and then put them into the media library so that if you want to repeat the lecture and listen to what I had to say, and I would highly recommend that since I give you a sample medical director scenario at the beginning of each one of our lectures. Or if you want to hear the cardiology section all over again, just to make sure that you got all the finer points, we're going to work on that. Yeah, okay. If not, we can figure something else out. But the most important thing is just making sure that you're getting used to my left thinking. And all three of you that are in here right now have to be thinking about what is my next appropriate step, what am I looking for, what am I seeing, what am I asking, and then how am I going to put a multiple injured person or a multiply ill person or what kind of algorithm I'm going to be putting together. I want to make sure this stuff is rolling off your tongue. Airway management, paralytics, dissociatives, hypnotics, just roll with it. Here we come with the neurocomplex tachycardias. I'm going to do adenosine. Oh, I see a WPW here, Wolf Parkinson White with a delta wave on this neurocomplex tachycardia. If I give CardioZem, we will be burying him next week. And the week after, I'll be employed by a landscaping company because I'll never be a paramedic again. These are the things I want to roll, and I want to enforce and then reinforce with you over and over and over again. All right, I see we're coming up to the end. Does anybody have one last question? Very good. All right, ladies and gentlemen, thank you for joining me. We will see you next week at 2000 hours Central Time, and I will have the papers delivered to you by email. Please read the first part only, which has to do with the neurocomplex, regular rate and rhythm arrhythmias. We'll concentrate on that first. I'm not going to cover entire cardiology in one day. We will take this piecemeal, and I'll see you next week. No, Jonathan, I appreciate you saying what you did, but quite frankly, this is what I love to do.